So this was a paper that I published earlier this year. Dr. Nupa Rajay from MGH was a senior author on it. It's one of my proudest papers this year, where we really took a stand, the principled stand, and rolled with it. And our principled stand is that Ig replacement therapy, so IVIG or sub-Q Ig, if available, should be given routinely following bispecific antibodies regardless of IgG levels. To put this in context, Ig replacement has had a long history in myeloma, right? There was a time most patients with myeloma, particularly receiving CAR T and bispecific, often develop hypogammaglobulinemia, which is where their antibody levels fall because normal plasma cells are also being depleted by the therapies. There was a time many years ago where actually hypogammaglobulinemia and immunoparesis was actually myeloma defining, actually, where if you saw that the myeloma cells were preventing the body from making normal antibodies and people were getting infections, that was called myeloma, just as an example. So it's always been very closely intertwined, hypogammaglobulinemia and myeloma. Many studies have looked at whether IgG replacement with intravenous immunoglobulin, IVIG, or subcutaneous immunoglobulin, sub-Q Ig, improves outcomes. As early as like 1950, there was a study of like intramuscular immunoglobulin, seeing if it worked, etc. Long history in myeloma. Most trials have been negative. Most countries, IVIG is very expensive, and so the consensus has generally been not to give IVIG routinely to patients with myeloma unless they're having frequent infections. Bispecific antibody recipients are at uniquely high risk of infections, particularly BCMA-targeted bispecific antibody recipients. So, teclistamab, elranatamab, linvoseltamab, etc. But all bispecifics have this issue because the moment you start knocking at normal plasma cells, you're starting to have people at risk of infections. And unlike with CAR T, with the bispecific, you're giving treatment again and again and again. You're depleting all their plasma cells, and actually really a nice analysis from the Memorial Kettering group showed that pound for pound, the risk of infections is actually higher with bispecifics than with CAR T cell therapy. Most of us assume that bispecifics are safer than CAR T, and in many ways they are, but when it comes to infections, bispecifics are far riskier than CAR T therapy or than anything else in a myeloma arsenal. How do we fix it? Most guidelines, including IMWG guidelines published 2 years ago, say that, well, when the IgG level falls below 400 grams per deciliter or 4 grams per liter, if I recall correctly, the unit conversion, when it falls below that threshold, to start IVIG supplementation at that point in time. In our paper, we make a very principled stand that we should not wait for then. 3 factors that we think about here. One, again, I understand the history of IVIG and myeloma is long, sordid, goes back well before I was born, but bispecifics are different. The risk of infections is very, very high, and honestly, infections are the highest cause of non-relapse mortality with bispecific antibodies, multiple myeloma, so it is a very big deal. That's issue number 1. Issue number 2, IVIG is pretty safe. If IVIG was a very risky, lots of side effects for it, I would say, or maybe, the benefit-risk ratio needs to be calibrated here. But I think here, IVIG is very well tolerated for our patients. They're coming in anyways every 1 to 2 weeks for treatment. Once a month IVIG is very easy to do. Subcutaneous immunoglobulin is actually even easier to do. And point 3, the biggest part of our argument is that, again, papers often talk about waiting for the IgG level to fall below a given threshold to start IVIG then. That's not scientifically based on anything. 400, in real life, the risk of infections is a binary risk. 400 is kind of an arbitrary number. More importantly, for patients with IgG paraproteins, which is probably about 1/3 to 1/2 of patients with relapsed myeloma, for those patients, they actually, the IgG level may be falsely normal. They may still have a normal IgG level for months after bispecific antibody initiation, but be a profound risk of infection. And at the end of the day, it's actually simpler to say, look, don't wait for the level, because if you have to wait for a level, how often do you check for the level? How do you correct for the IgG paraprotein, etc.? So many issues with it. Instead of preemptively waiting for IgG level and then starting IVIG, just starting it during cycle 1 makes a far simpler approach. And again, because the IgG level can be falsely elevated, because these patients are at risk of infections very rapidly, primary prophylaxis is the way to go. One critique that we've gotten that will be published shortly is that, the question is, well, if you give everybody IVIG from the very beginning after bispecific antibody therapy, some of them may not be eligible for vaccines. We typically recommend not giving vaccines to someone who is active on IVIG therapy. chemotherapy. I think both are important, and I do recommend to my patients they consider vaccinations against things like COVID and influenza, etc. But especially for bispecific antibody recipients, their immunoparesis, their hypogammaglobulinemia is so profound that honestly, every study that's looked at this shows that vaccines don't really work for them. IVIG often contains donor antibodies against things that are circulating in the ecosystem, including influenza, COVID, etc. So I would say in terms of preventing infections, IVIG probably is the way to go. And the last thing I'll say about this is that, at this meeting, well, two things. One, Dr. Meera Mohan presented data showing that even after stopping a bispecific antibody, you still need to continue IVIG for months afterwards because the risk of infections persists, kind of supports the point that we're making. And two, Dr. Mark Raw presented data from the Majestic 5 study looking at TEC, DARA, VR, or TEC, DARA, R, different combinations of teclistamab, a BCMA bispecific in frontline induction for transplant-eligible patients. I won't talk about the efficacy beyond a sentence. Basically, it worked amazing. 100% of patients achieved MRD negativity, 100% response rate. In the future, maybe those patients won't even need transplant. We'll see. We don't know that yet. But what I think was also interesting is many of us are nervous about bispecific antibodies in the frontline setting, again, because of this infection risk. In that study, almost everybody got IVIG, and there honestly were not that many high-grade infections at all compared to what we've seen before. So it's a good example here that in the same way that with high-dose melphalan, it would be absurd to give someone high-dose melphalan and not give them appropriate nausea prophylaxis, right, to prevent nausea from chemotherapy. I would say that in the future, it will be seemingly absurd to give someone a bispecific antibody and not give them IVIG prophylaxis as an important tool of supportive care.